I can tell you that in the, how long have I been doing this? I guess I graduated from my fellowship in 2003, so a very similar amount of time to John. That I can think of maybe 3 truly emergent cesareans in that period of time. And so it's very uncommon. And I also want to talk about the importance of the provider-patient relationship in this process. And, you know, John, you can talk about this as well. But paper really shouldn't be necessary in a lot of cases. In fact, Jessica, we keep referring to you just because we've had a lot of recent births with you, but as a doula. But one recently when a mom was admitted with a twin who said, you know, do you have a copy of my birth plan in the chart? Do you have a copy of my birth plan in the chart? And I said, of course, you know, there's a copy in your chart, but I know your birth plan. We've talked about it so many times. And the nurses have all been instructed about your birth plan, and you told them about your birth plan. And so, you know, if you'd like me to recite it, so you know I know it, I can do that right now. But I know your birth plan, and I'm also not leaving. Like, this is it. And I think she was in shock. Like, you guys aren't going to leave? It's either going to be you or John for this is it? And she was only 3 or 4 centimeters. He said, oh yeah, we don't leave now. This is it. And I think that's also uncommon at hospitals, to have your providers, a lot of times they'll swoop in at the end and catch a baby, and that's not really the way we roll. So we like labor support. I took doula courses. I'm never certified, but I did take the whole course. And
the really interesting
I love
thing
doing
is that, you know, an individual birth plan is very kind of novel thing, but most people's requests are pretty common to us. And they're things that we probably would offer at our hospital normally. And so every once in a while we get a request for something that, you know, requires a little bit of education and discussion, you know, lotus birth or something like that.
Which we do, by the way. Yeah.
But it requires more education of the staff to say, okay, this is how it's going to happen. This is how we need to translate the culture of the hospital in a way that allows it to happen. But most things that people request are things that we can do normally.
I mean, you know, another case example I wanted to bring up, you know, one of the birth plans that I read, I usually have people email it to me so I can take a look at it, and one of the things it said is, please do not circumcise my baby. And I was just like, oh my gosh, like this person actually thinks they have to write this down, that I'm going to just take their baby and randomly circumcise it. I mean, you know, that's unfortunate that people feel like they need to say that on a piece of paper. That is a major medical procedure that requires a consent, and of course that would never happen. But people feel so jaded by the medical system. They feel like if they don't write that down, so that could actually happen. And that's just unfortunate. Anyway. And so I just wanted to read this. This is Dr. Fisk, who is kind of thought to be the father of the gentle cesarean, at least in England and now Australia. He works in Australia. While couples having normal deliveries have been given more and more opportunities to be fully involved in childbirth, very little has been done to see how we can make the experience more meaningful for those having a cesarean. And I think that's true, and I think that's why you two brought us here today to talk about this. It can be gentle, just as vaginal birth can be gentle. But we all know and have experienced or have heard on blogs that vaginal birth can also not be gentle, just as cesarean cannot be gentle. So I think we need to think of it that way as well, sort of in reverse. This is a blog that I read a couple of weeks ago when I was preparing for this talk, and I just loved the story, so I just wanted to take a minute to read this woman's story. And I think I can read it over there. The scent of lavender fills the air and classical music is playing quietly. On the bed, the expectant mom, 42 years old, is calm, focused, and in control. With the birth of her second child just minutes away, the midwife, Jenny Smith, is giving her a relaxing massage. Her husband is whispering words of encouragement, just a tiny bit longer, and our baby will be in our arms. It could be the natural birth of any maternity unit in Britain, but this is actually an operating room. And this is where they're doing natural cesarean. You can go ahead and get the next one. At 9:24, our first sight of baby Finn comes as Fisk, who's the surgeon, gently lifts his head through the incision in mom's abdomen. In a normal cesarean, the baby would be lifted clear of the mom, the uterus, immediately, and the umbilical cord would be clamped immediately and cut within seconds. But the skin-to-skin cesarean, which is what he calls gentle cesarean, gives the baby an experience of birth that's closer to a vaginal delivery. Instead of being pulled out quickly, Finn's emergence into the world is slow and calm, and the cord remains attached for some moments. His body is being squeezed slightly by being still inside the uterus, which helps drain fluid from the lungs. The surgeon begins to lift Finn out of the uterus. In a normal cesarean, the focus would now be on the baby's ability to breathe unaided, as the umbilical cord would already have been cut. But in the skin-to-skin cesarean, the cord's left intact for several minutes. So the baby is still receiving oxygenated blood from the placenta, and the birth has been so gentle that Finn still seems to be asleep. Instead of being pulled quickly out of his mother, Finn is able to acclimate slowly to his new surroundings. Now he's beginning to make tiny sputtering noises, and he's becoming aware of the fact that his surroundings have changed dramatically. At this moment, though, he is literally suspended between his old life in the uterus and his life outside the uterus. His upper torso is outside his mother, but his lower body and legs are still inside. And officially speaking, he's not even yet born because his body's not fully emerged. Mom now has a clear view of Finn as his head is lifted up. And at the moment of birth, the surgeon lifts him from his mom's body and will hand him to Smith, who was the midwife, as you recall, who then will bring the baby skin to skin. And this is a crucial moment. They're encouraged to touch their baby, and we have to make sure that parents don't make the mistake of trying to touch those blue cloths and reach over. We really kind of need to go around those to preserve the sterile environment. Babies born by cesarean at that point are often crying, but that would not typically happen in this scenario. And please, everyone at the door, feel free to come on in. And this is very casual, so how are you? Lots of people that I know, too. And typically crying is the traditional sign that a baby's doing well, but we sort of discourage that and say that it doesn't need to be crying. It needs to be pink and appearing comfortable. And I think we all know what that baby looks like, that calm sort of baby. And then, I don't know if you could read this, John, but I probably, can anyone read
Within
that?
seconds, Finn is placed on his mother's chest for cuddle. I like that, cuddle. Studies show immediate skin-to-skin contact results in the baby was less likely to cry, has more stable temperature, and is more able to regulate his own breathing, and has better blood sugar levels. In a normal cesarean, Finn would now be on a resuscitation table, crying and throwing out his arms and legs. The skin-to-skin approach means that he can acclimate slowly to the world beyond the womb. So far, he has not cried. Lying on the mom's chest, hearing her heartbeat and voice, he is a picture of contentment.
So, talking a little bit, this is just a mom, skin to skin. This is not necessarily a post-cesarean mom, and not someone I know, but I love how happy they look in these pictures. From the medical and physical aspects of it, I think we all know this information, but immediate contact and breastfeeding within the first 30 minutes of life is crucial, and I think back in the old days, they used to say the first hour of life, and now we know it's really immediate. Immediate is probably best, as soon as possible. And I think in the old days, they used to say, oh, don't get a lactation consultant involved in the first 24 hours because babies are sleepy. The first 24 hours are crucial. You absolutely do need to have somebody come in and make sure that the baby's latching appropriately. And it doesn't have to be a certified lactation consultant. It could be the patient's mom who breastfed 4 kids who clearly knows what she's doing if she did it 4 times. Anyone can help in this scenario. It also improves the rate that when you get that baby on there fast, it improves the rate that the milk comes in. It improves the latch, so there's better latch scores overall when people assess breastfeeding later. It improves the skin temperature for the baby. I really meant it when I said the warmer is a cooler. This is the warmer. Dad's chest is a warmer too. It does not have to be mom. And I have had situations where mom had to go under general anesthesia during a C-section because her anesthesia was not working properly. And dad took that baby and did kangaroo care. And that was really exciting. It also improves, obviously improves maternal-child bonding. You can go ahead and go to the next slide. And socially, emotionally, it prevents postpartum depression. There's really good data out there about skin-to-skin and prevention of postpartum depression. And I think it improves the sense of maternal accomplishment. I think to have your baby be taken away after everything you've been through with a pregnancy, and even taken away where you can see it, it's just not with you, doesn't really make a lot of sense in terms of someone's social and emotional well-being. And I think it clarifies the partner support role. We were talking about this morning, that poor dads are partners that have to be, bye, honey, I'm taking the baby, and see you later. They have to walk away. I mean, I think you've experienced that with a lot of dads. I think you've talked to end partners about that process.
Yeah, it's just odd the way that the culture of how it happens has evolved. That we sort of created a culture in the hospital that separates a family at times.
I mean, it's great to have the partner hold the baby if mom can't do it, but why leave? They could do that right there next to the mom. They don't have to be in a separate room. You can go ahead and hit the button again. I don't have too many more slides, by the way, just we're going to talk about that. But, and this was I don't know who Pam B is, but she's a genius, because she wrote this on this blog. Taking it a step further, how wonderful would it be if all mothers could expect to be treated like their births are amazing, magical, and worthy of respect and consideration. No matter how our babies enter the world, birth remains one of the most powerful and unforgettable experiences we will ever have. And I think that is undeniably true. So, you want to talk a little bit about this, John? This is your baby right here.
So this is interesting. I think deep down I must have been like an anthropologist or something. Because, just like families and most other institutions you have, we all have cultures that we participate in. And the culture in the hospital is very interesting because it's each team that's involved in a delivery has its own culture. And so it's important to understand what that culture is and then how it needs to be translated to institute a certain amount of change. So when a C-section happens, there are 4 teams of people involved. There's a team who actually does the surgery, and so they're sort of responsible for the surgery. There's a team that is doing anesthesia. There is a team responsible for the baby, and then there is an OR team who's responsible for the logistics of the OR. And they're all different. They all have their own standards. They all have their own cultures. And so the work that we've done at Memorial has a lot to do with understanding what those cultures are and how we all work together to affect the gentle cesarean and how those cultures can be adapted. Some of the things are really simple. For example, in order to get a nice, warm, dry baby to mom, we needed an extra baby blanket or 2 packed in a C-section set, which comes from the basement of the hospital.
Sterilized blanket.
Sterilized
It's got to be sterile.
Central processing, and so it was it seems like a simple intervention, but we actually had to change the way that